Hi, I'm Kristen Hodgson, IVF mom, proud women's health advocate, and co-founder of Rescripted.
And I'm Dr. Jenna Khan, a board-certified OBGYN, fertility specialist, and mom of two.
And from first period to last period, we're diving into the women's health topics that matter most, from periods and fertility to pregnancy and menopause.
Through expert interviews and candid conversations, we're empowering women to take charge of their health by expanding the discussion beyond what's typically covered in the doctor's office.
It's time to stop guessing when it comes to our health. Now let's dive in for the real science-backed info you need to be the expert in you. Hi, everyone, and welcome back to From First Period to Last Period. Hi, Jenna.
Hi.
How are you?
I'm great. How are you?
Good. So last week we dove into my birth story. So if you missed it, make sure to go back and catch up. So what's on our minds today when it comes to women's health? For me, I saw this hilarious bill making its way through the legislature in Ohio that could make ejaculating without the intent to conceive a felony with a potential $16,000 fine. I thought that was great. The authors of the bill say that they wrote it as a joke to highlight the absurdity of laws that control women's bodies, but don't do the same for men. Did you see that, Jenna?
No, that is hilarious. I think I'm glad that it was a joke. But really, it was like these, ejaculating is such a big part of like a lot of men's lives. And I feel like for these men who are making all of these laws about women's bodies, like, yeah, throw this in their face.
Well, yeah, it's like, get a vasectomy. Like, I feel like if I wasn't infertile at this point, I'd be like, I probably should either way, because you never know. It's like when you don't want to get pregnant, that's when it happens. But I'm like, no, my body's been through enough. Like, you can get a vasectomy.
Yeah. I mean, no, I like, but whether that like this ejaculating is like with just intercourse or like masturbation, still, it's like,
Right.
just, I think, but that is a like severe restriction that would hopefully wake up some legislatures to be like, oh, right, we shouldn't be controlling women's bodies.
Absolutely. Yeah, it's such a double standard for sure. So with that hilarity under our belts, we've got a great episode for you today. First, in Her Story Unfiltered, Erica opens up to us about her harrowing and ongoing journey with fibroids, which has involved multiple surgeries. So if you're ever wondering about treatment options for fibroids, we're diving into that and sharing some important questions to ask your healthcare provider so you can avoid the challenges Erica has faced. It's definitely a must listen. Then in Own Your Health, we're going to take you through some of the hottest topics in women's health right now, perimenopause being one of them. We're also going to have our friend registered dietitian Anna Bonangle on, who's going to help us break down how much protein you actually need to be eating in a day. I saw a hilarious video from she's on social at Big Time Adulting. I don't know if you follow her, but she said that if you take the amount of protein that will kill you and subtract by 10, that's like what some health influencers are telling us we need in a day. So that resonates. So we'll find out exactly how much you should be eating from a registered dietitian. And lastly, in Women's Health in the Wild, this is really cool. We're going to explore a groundbreaking study out of Columbia University on a drug that could potentially reverse ovarian aging. So excited to dive into that. Her Story Unfiltered, raw, real, and rescripting women's health, one powerful story at a time.
This week in Her Story Unfiltered, Erica T opens up about her painful journey with fibroids, multiple surgeries, and how it all impacted her fertility. Her story is a powerful reminder of what shouldn't happen in women's healthcare and how crucial it is to trust your instincts and seek a second opinion if something doesn't feel right. Now let's hear it.
Hi, my name is Erica, and I am in St. Louis, Missouri. My fibroid story started in 2008 when I was diagnosed. During those same first 2 years of diagnosis, my OBGYN did a laparoscopic surgery and decided not to remove any fibroids at that time, but ended up removing my appendix. And that was pretty alarming. And I just lived with the symptoms until 2014 when I had my first abdominal myomectomy, where I had 22 fibroids removed, including endometriosis from both of my ovaries and cysts. And unfortunately, in the recovery room from that surgery, I experienced hemorrhaging from so many cuts being done to my uterus, and I was in intensive care for about 7 days. I also experienced an allergic reaction from the pain medication I was given in the OR. Fast forward, I dealt with infertility. I did decide to go vegan, and that did help the infertility, though I was unable to carry a child because of the damage that had been done to my uterus. I've been diagnosed with fibroids in 3 different occasions after 3 different treatments, and I am still in a space where I have uterine fibroids. I am now approaching 50, unable to carry a child, and have to undergo yet another procedure. And I'm not sure if that's going to be a hysterectomy or uterine fibroid embolization, which is something I learned about very late in my fibroid experience.
Wow. I feel like, well, first of all, Erica, I'm so sorry that you've been through so much. And thank you for sharing your story. Um, Jenna, do you want to sort of dive in? And I know that fibroids don't automatically mean infertility. Like, what kind of went wrong in your professional opinion here?
Yeah, I think there's a lot to unpack here. Um, First and foremost, fibroids are really common. We see them in um, like the lifetime risk of having fibroids is up to like 70% of women in white women and 80% in African American women. So they're really, really common. And whether or not fibroids will impact your fertility really depends on where the fibroids are and how big they are. Um, Also, whether or not fibroids will cause symptoms like pain, pelvic pressure, constipation, frequent urination, stuff like abnormal bleeding. Again, also depends on how big the fibroids are and where they're located in the uterus. And they could be like what we call submucosal, so like in the cavity where a baby would grow, in the muscle, and then like on the outer part of the uterus. I think probably the biggest thing here is like pre-surgical counseling. When you want to retain your fertility and you have a lot of fibroids, your only option is and the fibroids are thought to be causing infertility because they're like where a baby would grow or they're changing the shape of the uterine cavity. Really, your only option is a myomectomy, which is a fibroid surgery. Other options for managing of large multiple fibroids that are causing issues with symptoms are like one, hysterectomy. Two, there's this uterine artery embolization where you're sort of blocking the blood flow to the uterus, and that causes some shrinkage of the fibroids. Um, but this is not recommended in patients who desire future fertility because it can relate to issues with like establishment of the placenta, embedding into the uterus. Um, and then um,
A myomectomy is usually pretty minimally invasive, right?
It depends on how many fibroids you
Okay.
have and how big they are. And so,
Okay.
if there's only a fibroid inside of the uterine cavity, often it can be removed with a hysteroscope, which is like a little camera that goes inside and you sort of like shell out the fibroid that way. Um, if it's in the muscle um, or on the outside, if there's one or two, a few, like a handful, you can maybe do it laparoscopically or like robotically, minimally invasive. But if there's lots of fibroids or they're really big, then we're looking at an abdominal myomectomy. The fibroids are hormonally sensitive. And
Okay.
so they grow as long as you're having regular menstrual cycles, they will continue to grow. And so if there's a fibroid that's the size of like a sesame seed or like a little tiny marble that you might not be able to see during a surgery to remove, that will just grow post-operatively like into the future. And so just because you are having a fibroid surgery to remove all fibroids that you see doesn't mean that you won't have more fibroids in the future. And that's a really hard thing to like wrap your head around as a patient. Like, what do you mean I have more fibroids? I just had this big surgery to remove all of them. How is it possible that I have more? And then when it comes to a fibroid surgery, when you're removing so many fibroids, again, like I mentioned, it can sort of be like a uterine reconstruction. And one of the problems that I see as a fertility doctor is that that can leave a lot of scar tissue. And there's unfortunately at this point, like no way around that. And the scar tissue can be located just like within the muscle of the uterus, but could also impact the cavity of the uterus. And so if there's scar tissue in the cavity of the uterus or the endometrium where a baby would grow, that really impacts implantation and growth of a pregnancy. So that sounds like what she's probably struggling from. And so, you know, fibroids are really, really challenging, especially when you have a lot of them when it comes to fertility. But I think really a lot of her frustration probably would have been mitigated if she had had appropriate pre-operative counseling.
Mm-hmm. Because she could have kept it in mind that her fertility was important to her. Like she could have communicated that her fertility was important to her.
Yeah, and I'm sure that she did communicate that, but like talking about the risks of scar tissue, you know, maybe she would have followed up with a fertility specialist sooner, or looped in a fertility doctor as soon as she was considering having a myomectomy. You know, I have a lot of patients who see me prior to a myomectomy, or who have fibroids and want to get pregnant. They want to know what their options are, and they decide to freeze some eggs before having their fibroid surgery, or freeze some embryos before their fibroid surgery, because fibroid surgeries that with a lot of fibroids, there's a lot of blood loss. It can impact your ovarian reserve. And so freezing something up front can be helpful. And then also post-operatively, if you have lots of scar tissue that either takes multiple surgeries to repair or cannot be repaired because of the dense scar tissue, then you potentially have something in the freezer that you could use for a gestational carrier in the
Yeah.
future.
Yeah, that's where my mind kind of went. But I hadn't realized that the scar tissue could potentially also affect like ovarian reserve too.
It's not that the scar tissue impacts ovarian reserve, but the blood loss from the surgery can
Oh,
impact ovarian reserve. And so it doesn't always happen, but a myomectomy has been shown to decrease ovarian reserve a little
right. And
bit.
if you know you want to have kids in the future, it like doesn't hurt to be preventative and freeze your eggs or,
Yeah.
take preventative measures for
Yeah.
sure.
And then there are some things that can be done intraoperatively to prevent intrauterine adhesions, like there's scar tissue. So scar tissue inside of the uterine muscle is hard to prevent. But if you have someone who is like a reproductive surgeon, or like has the fertility at top of mind, you could place a small balloon inside of the uterus temporarily after surgery to like keep the walls of the uterus away from each other so they don't stick together and scar together. And so that's one
Mm-hmm.
thing that you could do at the time of the surgery. But when you're removing so many fibroids and there's potentially a lot of blood loss, the I guess priorities sort of change at the time of the surgery, from like, let's save this patient's life, from like
Of
let's
course.
restore fertility, let's preserve fertility, to like, we got to make sure this patient comes out of the surgery.
And I just want to, just so I have a complete picture, like what is a fibroid exactly? Because like in my mind, I'm like, well, how is this different than like the scar tissue from a previous C-section?
Yeah, so the scar tissue is actually pretty similar, but so a fibroid is um, a it is a benign tumor inside of the uterus that is made up of like uh, smooth muscle cells that just like
Okay.
grow and grow and grow. And it's usually surrounded by a capsule, and so removing them is usually pretty easy, in that you just like open the capsule, plop them out like plopping out a gumball that is like stuck in sand, sort of thing.
Oh, interesting.
And but the scar tissue that can result from a myomectomy is very similar than the scar tissue that can happen from a C-section. Although it can be worse after a fibroid surgery, myomectomy, because there are theoretically multiple incisions on the uterus
Okay, so
to
it
get
depends
out
on how many
multiple
there are.
fibroids. Yeah, so the more incisions there are on the uterus and where they are really can impact the degree of scar tissue that results.
Okay, yeah. So again, the message being just, make sure your provider is on the same page as you and really counseling you ahead of any sort of surgery, and all your options ahead of time so that you can and it sounds like Erica's been great at advocating for herself. But
Yeah, and if you're undergoing a surgery that you think may impact your fertility, or a surgery that you are choosing that method of surgery because you would like to
yeah,
have children in the future, then maybe meeting with a fertility specialist beforehand to ask them questions and have them weigh
yeah,
in, maybe
that's
that
a
they
great
could
point.
communicate with the surgeon, could be helpful.
Yeah, some fertility centers even have like gynecological
For
surgeons
sure.
on staff. Yeah.
Own your health. Ask us anything. Your questions and expert answers, because you are your own best advocate. I have to say, it feels like everyone is talking about perimenopause lately.
Yes, 100%. I feel like I've been seeing it everywhere. And my co-founder, Abby, actually, we both just had babies in the past 6 months and are in our, I guess, mid to late 30s. And we're like, wait, so we're finally done having kids and now we have to worry about perimenopause. um, but so one of our listeners wrote in and asked, my periods have become lighter and less frequent. Less frequent. Could this be a sign of perimenopause?
So the answer is that it could be. Like I've mentioned in prior episodes, a period is like a vital sign telling you the health of the brain ovary communication. Menstrual cycle length is anywhere from 21 to 35 days, and the variability between cycles is usually less than 7 days.
Hmm.
And period length, so how much time that you're bleeding for, is usually at least 3 days long, but it can vary in how heavy or light it is from person to person. And cycle length, meaning like from the first day of the period to the next first day of like in the next month, and the quality of the bleed can change as we age, but that doesn't mean that it's something pathological.
Yeah.
And so if you're concerned about the way that your menstrual cycle is changing, bring it up with your OBGYN. And if you have menstrual cycle changes and you're thinking about becoming pregnant, that might be a reason to reach out to a fertility doctor sooner rather than later.
Yeah. How do you, as a, fertility doctor, what would like the big red flag be that like someone might be in perimenopause? Do they need additional testing? It's not just the periods being lighter and more frequent or less
Yeah.
frequent.
So, as we age and as we sort of like enter this perimenopause transition, what happens is the cycle length becomes shorter and shorter. So, like if you
Oh,
had
shorter. Okay.
like a 28-day menstrual cycle previously, and now it's like 24 days and 21 days, that is a sign of diminishing ovarian reserve, or like ovarian or egg pool sort of getting smaller and smaller. The
Mhm.
brain's having to work harder and harder to get an egg to grow.
Yep.
Um, and sometimes the signal from the brain is just so strong that it causes like an egg to grow earlier, then ovulation happens earlier, you get a period sooner, and so the cycles get shorter and shorter.
Yeah.
After they get like between like as after they get, you know, shorter in length, then they start to space out where you start missing periods. And so
Mhm. Okay.
um it's sort of like, yeah, so you have like your regular menstrual cycle length, then it gets shorter, and then it gets longer until you're without a period for a year. And that is the definition of menopause, when you've been without a period for a full year due to lack of ovarian functioning.
Yeah. Well, that's why I think perimenopause education is so important. And we just added a whole, category for this on our site at rescripted.com because like you don't know what you don't know. So I had no idea what you just said about how first your periods can become more frequent before they become less frequent. Like that's so important for us to know. Like
Yeah.
heading into my late 30s. Like that's, you shouldn't have to be not having a period before you're like, oh wait, some of these symptoms I might be having could be not even menstrual cycle related, just like other symptoms could be related to perimenopause.
Yeah, and the quality of the bleed has less to do with that brain ovary communication. So
Okay.
if the bleeding, if you used to bleed for 5 days and now you bleed for 3 days, that doesn't mean that there's something wrong.
Okay.
If you all of a sudden start having really, really heavy bleeding, that might be a reason to go see your OBGYN or your fertility doctor, because maybe there's a polyp or a fibroid grew or something like that that can change the quality of the bleeding to make it heavier.
Hmm.
But if you're still bleeding between like 3 to 7 days and it's not doesn't feel too heavy for you, that just might be with a normal fluctuation, with time.
Yeah. So, as a fertility specialist, if you do have a patient who you think and test results might lean this way, is in perimenopause, can they still get pregnant? Like, what is the prognosis there?
So, as I sort of mentioned, like menopause happens from the egg pool, or the quantity of eggs that you have depleting, but also what happens with time is the quality of those
Quality.
eggs declines. And so the quality of the eggs, which is like how old the eggs are, how old the patient is really what determines cycle fecundability, or ability to get pregnant in a single cycle. And treatment success with fertility treatments and IVF. Certainly, like if you're doing IVF and you have a lower number of eggs and you're headed into menopause on the earlier side, that can
Mhm.
impact cycle success. But really, it's the age at which you're entering this fertility journey that dictates ability to get pregnant.
Yep. Okay, so you can be in perimenopause, but as long as you are yielding eggs in an egg retrieval and potentially still
Yeah.
ovulating.
Yeah. So yes, and so when we're doing an assessment of perimenopause, we're checking hormone levels, and if someone is truly perimenopausal, like I mentioned, the brain is working really hard to get the ovary to respond. So those brain hormones, FSH and LH, are going to be really, really high.
Yeah.
When those hormones are really high, it's less likely that somebody will have a good response to fertility medications.
Hmm.
So that can be really challenging, but it's not impossible. It just might take more rounds. And it's really variable in person to person. I wouldn't say it's impossible to get pregnant when you're in the perimenopausal transition, but it's certainly a lot harder.
Got it. That's great insight. So someone else wants to know your advice for timing sex at home when you're trying to conceive. So how many days out of the month can you actually get pregnant? Because I was like 27 and, married before I realized that you have to ovulate to get pregnant, which is so embarrassing.
Very true. There's really like 5 or 6 days of the cycle where you actually can get pregnant. And as you mentioned, it all circles around ovulation. So ovulation is the process where the egg is released from a follicle in the ovary. And once this egg is released, it can survive for up to 24 hours. Peak fertility is really the day before ovulation happens, and that's really when you're like seeing a positive ovulation predictor kit test at home if you use those. Um, but also, healthy sperm can live in the reproductive tract for up to 5 days, and so if you have sex, 5 days before ovulation, there could still be viable sperm in there um, to get pregnant. And, so this sort of goes both ways. Like if you are trying to use the rhythm method to not get pregnant, you want to make sure you're not having sex in like the 1 week prior to ovulation and like the day after ovulation. Once you've ovulated, the chances of pregnancy really go down pretty quickly. Um, and then if you are trying to get pregnant, you don't actually need to be having sex every day. You could do like
Yeah.
every other day in this fertile window because, again, you're just compounding more and more sperm that really should be there ready and waiting for the egg. So like 5 days before the expected ovulation is when that window starts.
Yeah. So the whole sperm can live up to 5 days, I think, is where a lot of people go wrong as far as like if you're just tracking, like you said, with the rhythm cycle, or like I have the aura ring, or if you're just kind of using like the fertility awareness method versus a birth control method, you might not catch ovulation until it's gone by. And so if you had sex within that 5 day window ahead of time, you could get pregnant.
Yeah, yeah. And that's sort of like why, um, you know, you don't necessarily need to be tracking ovulation to get pregnant. Like
Right.
if you have regular periods and you're having regular intercourse, like at least twice a week, you really should be hitting that 5 to 6 day window
Yeah, yeah,
to
yeah.
get pregnant. And so if you're not pregnant after a year of trying, that's sort of where how even if you're not tracking ovulation,
Mhm.
you still that's really when you should be seeing a fertility doctor if you're less than
Yeah.
35.
I meant that more for people who like might not want to get
Oh
pregnant
yeah.
and who are like using, fertility trackers and stuff to not get pregnant. Because that's like just a fact that a lot of people don't know is that like it's kind of the time leading up to and maybe the day after ovulation. It's not, you know, after that. Like it's kind of
Yeah,
before.
once you've ovulated like 24 to 48 hours after your expected ovulation, then you can have sex. You're not going to get pregnant at that time. But the
Yeah.
problem is that um with like doing this natural cycles is that your cycle length and therefore the day in which you ovulate can vary a little bit from cycle to cycle. And so
Hmm.
unless you're like really sure when you're
Yeah.
ovulating, that if you're trying to prevent pregnancy, that window it can be actually longer of when not to have sex can actually be longer than 6 days, like
Yeah.
more like 10 or 12 days.
Yeah.
If you have cycle length variability.
Yeah. Well, we'll talk about this in a later episode, but I have a friend who like knows exactly what she's ovulating. She gets like ovulation pain. Like I'm like, who are you?
Some people are
Like
like really in tune with their bodies in
I
that
know
way.
it's crazy. I feel like I'm in tune with my body, but like with the whole ovulation thing and PCOS, I'm like, yeah,
Yeah.
no, that'll never be me. But I'm a little bit jealous. um, awesome. Well, so we're going to be doing a little nutrition segment in Own Your Health every couple of episodes or so. Our friend registered dietitian Anna Bonengal is going to be sharing how much protein do you really need each day. And so let's listen to what she has to say.
An active to moderately active woman in her 30s interested in supporting overall health as well as building muscle for an active metabolism as she ages needs to be doing strength training 2 to 4 times a week and eating enough protein. So what does enough protein mean? Here's the numbers. You need to be eating 1.7 to 2.4 grams of protein per kilogram of body weight, or that's about 0.8 to 1.1 grams of protein per pound. So if you weigh 150 pounds, we're talking about 120 to 165 grams of protein per day. And that also means eating protein at regular intervals throughout the day. This is equally as important. You want to aim for 30 grams of protein within 30 minutes after exercise and a regular dose of 30 to 40 grams of protein at each meal and 10 to 20 grams at each snack. So to make this happen, here's what you do. You can get about 30 grams of protein, enough for a meal, with just 4 ounces of fish, chicken, turkey, meat. So to eyeball this, 4 ounces is just slightly larger than the palm of your hand. You can also get 30 grams of protein with 1 cup of cottage cheese or 1.5 cups of Greek yogurt or 4 eggs. If going for plant-based protein, you're going to need to eat more quantity of food. To get 30 grams of protein, you would need to eat about 1.5 cups of tofu or 2 cups of cooked beans. So, in the morning, add a healthy dollop of cottage cheese to your eggs, snack on Greek yogurt, jerky, or edamame. For lunch and dinner, go for at least 4 ounces of meat, chicken, or fish, and you got it.
I did not realize that edamame had protein.
Good to know. Were you writing down the numbers? I feel like
Yes, I
you were
was.
both writing. Me
I
too.
was.
I was like,
Well,
I
it's
gotta
funny.
calculate this for myself.
Well, the reason I wanted to have Anna on, she's one of our advisors and she's fantastic. She like kind of breaks down how to get that in. I feel like so many wellness influencers out there like kind of just say like Caitlin Murray said, like just take the amount of protein that will kill you and subtract 10. Like how? And like that's so interesting. Cottage cheese. I've actually seen a lot of people putting cottage cheese in their scrambled eggs. I like have a texture thing about cottage cheese,
Me
but
too, but actually, if you blend it, it takes away, it changes the game.
with eggs.
So yeah, if you blend the cottage cheese and then you can mix it with eggs, or if you like blend it and put it in like pasta sauce and make like a blush sauce or like vodka sauce, it
Oh my gosh,
so it doesn't have that like clumpy texture. It just like thickens it a little.
That's actually a really good way to get like my kids to eat more protein too in the pasta sauce.
Good point. I should start doing that too.
That's amazing.
Because you can like add it to muffins. You can put it, pasta sauce, eggs.
Yeah, I would say the biggest game changer for me when I was working with a dietitian was like focusing on adding to my plate versus taking away. Because like for so long, I mean, like we both grew up in the 90s, like diet culture. And for so long, it was like I feel like I did Weight Watchers at like 20. Like, so, like, I just can't, I don't know.
It was all about like restricting like this, like
yeah.
the South Beach diet, the Atkins diet, like all these diets are like all about restricting. But, I refer a lot of patients to dietitians in my practice. And so when I first started, I had meetings with these dietitians to just understand their philosophy, how they practice, and like how I could, work with them. And that's like their philosophy now, like add more things to your plate. If you're adding more healthy things to your plate, then you're probably going to be eating less of the junk.
Yeah, absolutely. Love it. Women's Health in the Wild, must reads, must sees, and must tries for your wellness journey. So Jenna, I can't wait to hear what you have to say about this. I came across this exciting new research from the Vibrant study led by Columbia University Fertility Center, investigating the use of the immunosuppressant, I'm probably saying this wrong, rapamycin.
Yeah.
Preliminary results are really promising, suggesting that it could reduce ovarian aging by up to 20%, potentially delaying menopause and extending women's reproductive health span. This is like the golden, nugget of like research right here. Like everyone wants to know how to stay younger, and especially when it comes to their fertility. So can you kind of explain like what this means for your field and
sure,
potential next steps?
So, just sort of like circling back to what we were talking about earlier in the episode, that age-related fertility decline is a well-known problem, and age is the single most important factor in predicting fertility and success with fertility treatment.
Yep.
As we age, we're constantly losing eggs, and when we lose all of our eggs, the ovary stops functioning and producing estrogen, and we stop getting periods, and that's called menopause. The rate that we lose our eggs is different from person to person. That's a large reason why fertility treatment success can vary so much from person to person. Also, why the timing of menopause can be so different from person to person. Hormones, namely estrogen, is not just important for reproductive health. And with the cessation of ovarian function and low estrogen comes some health-related issues that women experience menopause. So low bone density, increase in cardiovascular disease, hot flashes, insomnia, brain fog, just to name a few. And so figuring out how to slow this process down could be a huge win for a lot of women and for the science of aging. Rapamycin, as you mentioned, is a drug that's typically used to prevent organ transplant rejection, and it's been shown to slow the rate of egg loss in animals. And now Columbia University is trying to see if this holds true in humans. The study is still in the recruiting phase, but preliminary results in a small subset of patients has at least showed that the medication is really well tolerated and that it may be showing some benefit up to 20% decrease in ovarian aging, which is in the rate of egg loss, which is certainly promising. So definitely more to come on this front. Well, I'm sure we'll be seeing a lot from this group in the next 2 years. But how this might change my practice is, I do see a lot of women in their late 30s, early 40s with a more accelerated egg quantity loss. And therefore IVF is a lot harder for them. Pregnancy is a lot harder for them. It's important to know that like the number of eggs you have doesn't really predict your ability to get pregnant or time to pregnancy, but it has a lot to do with how the success of IVF. It's sort of a numbers game. The more eggs you have, the more will fertilize, more embryos. I'm not sure that this is going to impact the quality of the eggs. because,
Right, right.
how long those eggs have been sitting in your body doesn't change,
Mhm.
maybe just the rate at which we lose them. So, and the functionality of the ovary in general. But even if someone has diminished ovarian reserve at age 38, there's still a decent number of good quality eggs in the ovary at that time. And so if we could get, if someone started taking this earlier on, we had more eggs to get, then maybe they would do better in an IVF cycle.
Yeah.
I think there's a lot of potential for this in my field. I even see patients that are like in their early 30s that have an accelerated quantity of egg loss, so diminished
Mhm.
ovarian reserve in their early 30s. So that could really help them as well too. And so
I guess my
this,
question is like, how is this used? Like, is it like a Lupron kind of thing where you like do it for a couple months leading up to your egg retrieval, or is it like an ongoing? Like, I guess
that's a good
you
question.
know.
I think that it's more something that you take like when you're younger to prevent like
Okay.
more rapid decline of egg reserve. And maybe that involves like screening at a younger age by the OBGYN and then certain select patients. I don't think everyone's going to be taking this, but who knows? I mean, this is just the way beginning stages of this research to see like in this small group of patients, does this help? And then, I think there's going to need to be some studies on like, how long do they need to be treated to see a benefit? Can it just be when they enter fertility treatment, or should this start with the OBGYNs and screening patients with an AMH,
Yeah.
when they're 30? And if they have a lower reserve, then maybe start them on it, earlier.
Yeah.
Um,
Can we just screen everyone at 30? Like, can that just be a standard practice
yeah,
already?
so at this time, the American College of OBGYN does not recommend screening like doing an AMH screening on everyone. And so just for everyone listening, AMH stands for anti-Müllerian hormone. And it gives us a sense of like how much gusto or oomph the ovary has in it. It doesn't predict ability to get pregnant or time to pregnancy, but it does really help us determine how successful an IVF cycle might be. And so, it's not recommended for routine use
Do you
in.
think that's because they don't want like people to sort of jump to conclusions about their
Exactly,
fertility?
because it's not like a true fertility test. Like,
Yeah.
someone with a low AMH could get pregnant before someone with a high AMH. It doesn't predict time to pregnancy. But, on the flip side, I think that it probably should be utilized on a more routine basis, not for predicting fertility, but maybe if someone should start seeking fertility preservation,
Yeah.
because a
Interesting.
low ovarian reserve or a low AMH might predict a sooner time to menopause. And whether that's
Yeah.
like 5 years from now or 10 years from now, it's a little bit hard to predict, but that might be the first red flag to like go see a fertility doctor for some counseling.
Yes, I do agree on the fertility preservation, especially if you feel like you're like a bunch of years out from potentially being able to get pregnant,
Yeah.
for sure. Well, really exciting stuff. I love the fertility field and just like going to ASRM every year and like seeing all of the research being done. It's still such a young field and like there's so much still to come as far as like what we know about
Yeah.
fertility and like I'm really excited to hear more about like learn more about like the autoimmune connection to fertility and yeah, so it's a really exciting field to be in, I'm sure.
Yeah, I agree. There's so much coming out, and I'm really excited to hear more about the study when they have recruited all their patients, and we have a lot of patients to see what the results are.
Amazing. The future of fertility is bright.
Indeed.
Well, thanks, Jenna. And we'll chat next time.
Can't wait. See you later.
See you soon. Bye. Thanks for tuning in to From First Period to Last Period. If you enjoyed today's episode, be sure to hit subscribe so you don't miss any of our future conversations.
And don't forget to share this with your friends, because when it comes to women's health, we all deserve to be informed, empowered, and supported.
Still have questions? Email community@rescripted.com for a chance to have yours answered on a future episode. For more science-backed women's health content that meets you exactly where you are, head to rescripted.com or follow us on social @HelloRescripted.
We'll see you next time with more real stories and expert advice.